Good afternoon, everyone. My name is Deanna Fenton, Program Manager here at the Alliance, and I'd like to welcome you to today's webinar, End-of-Life Conversations, a Collaborative Approach to Donation. Before we begin today's presentation, there are just a few reminders that we'd like to go over with you all. For optimal visual and audio experience, we do recommend accessing these webinars in the Chrome browser, so if at any point you encounter any issues, please log back in using Chrome. If you are already using Chrome or continue to experience these issues, please try dialing in using the phone number that was provided in your confirmation email. Now, to those of you who are joining us on this platform for the very first time, please take note of the chat feature that's located in the bottom left-hand corner of your screen. This chat should be used to pose any of your questions to our speakers. If you have any questions that come up during the course of the webinar, please feel free to submit them at any point in time. Once the presentation is complete, we'll have some time for our presenters to address as many of your questions as time allows. Now, for those of you who may be interested in our upcoming webinars, please note registration is currently open for our next innovation webinar, Technology Tools to Improve Organ Acceptance. That's coming your way on October 15th at 2 p.m. Eastern. Registration is also open for our upcoming transplant webinar entitled Determining Eligibility of Blood Type B Candidates for Transplant with Blood Type A2 Kidneys. Be sure to join us for that on October 24th at 3 p.m. Eastern. For more information on either of these webinars or to register, please visit our website at organdonationalliance.org. Now, for anyone interested in obtaining continuation education credits, we are offering one Set C credit and one nursing contact hour for this webinar. We do also offer a certificate of attendance, so for anyone seeking CEs that are not available, we recommend submitting a certificate of attendance to your credentialing organization as proof of your participation in this educational offering. Everyone joining us today is entitled to claim either of these credits or certificates. Prior to receiving your certificate, you will be asked to complete a brief online evaluation that will allow you the opportunity to provide us with your valuable feedback. If you're listening in a group, as many of you are, please be sure to get the evaluation email from your group lead. As a friendly reminder, you'll have 14 days to complete your evaluation and claim your credits for nursing, and for Set C, you'll have 30 calendar days. Now, at this point in time, I'd like to introduce our moderator, Amanda Habermill, Manager of Hospital Development at EndofLife. Amanda, thank you so much for joining us today, and at this point, I'll go ahead and turn it over to you to introduce both of our speakers.
Thank you. Our first speaker is Dr. Salvador Guerrero. Dr. Guerrero is a medical physician by training and a family resource coordinator for Donor Network West. He has successfully been in the OPO world for over 25 years and has worked in the fields of community outreach, public relations, hospital development, and mentor in many capacities at different times. Overall, a family care specialist, he was recognized for his work in the Hispanic media, national and international. He was president of national organization named the Association of Multicultural Affairs in Transplantation. He has made transplantation and donation a passion in his life and continues to support and promote the gift of life everywhere he can. He truly believes that his spirituality has given him the strength to continue with his endeavor in this field of medicine and the support of his family to share what he has learned throughout the years. Our second speaker is Sherry Barger. Sherry has worked as a donation advocate, family services representative at TransLife, and as a multi-faith chaplain at Nerman Children's Hospital in Lake Nona, Florida, where she is focused on palliative care consults and end-of-life conversations. Sherry is a certified member of the Green Cross of Traumatology with certifications by the International Critical Incident Stress Management Foundation, with certifications in critical incident stress management for both groups and individuals. Sherry is a published author with publications focused on the role of spiritual care in organ donation. Her areas of expertise include the development of training materials for donation advocates, donor family service team huddles, mindful questions for authorized requesters, and active listening within palliative care conversations. I'm going to turn it over to you, Dr. Guerrero.
All right. Good morning, everyone. So first of all, thank you for being here. I want to acknowledge everyone who's here today, especially our staff here at the Alliance. Without you, we can't make this happen. And obviously, with participants, it's your interest and your valuable time that makes this worth an opportunity to enhance and better our training. Here I have the opportunity once again to share in our experiences and to achieve our goal, which is to help and save and heal more lives. So again, once again, we start off with the end-of-life conversations, a very difficult conversation in itself, and obviously there is a lot of myths behind this, and sometimes even culture and religion put a burden on our communication as we go on with going on site and evaluating the next opportunities to have a communication with the family. Here at Donor Network West, we have a process guide where we try to educate our community through community outreach and public relations media to get out in the community and obviously work as best we can. Also, that includes educating our partners in the hospital. Hospital is our best friend, our best communicator, and our referral. Our referral is very important because without them, we won't know if that possible potential exists or not. So we've established a better communication style with our partners by being available and giving them a familiar face to recognize. One of our best practices at this point is what we've actually done, which is regionalization, which is basically having the same staff come to the same hospital as best as possible within that time frame. Many times it can't be done, but it will help the hospital staff, nursing staff, the doctors to actually recognize a familiar face. In that process, they get to know us and to trust our ability to communicate with the families, offer support, and in due time offer the option of donation as we move forward. One of the things that we also like to remind ourselves is how do we rate ourselves as an organization or as persons that we actually go on site? And I like to mention this as, the acronym of RATE. We have to always remember the respect that we need to offer to our hospital partners, our community, and obviously the families that we work with. We need to listen to our families once we're there and work with their concerns. Sometimes their concerns are not necessarily in reference to the diagnosis of brain death or end-of-life decisions. Their concern is, what am I going to do next if he passes? Am I going to pay the rent? Am I able to maintain my kids? Do I have to communicate to a family member who really doesn't like me as a spouse or have had difficulty communicating? So we have to try to listen to their needs. Now, acknowledging this is very important, to acknowledge their difficult decisions, their pain and suffering. As we mentioned, grief is very hard to deal with, and it depends also on our culture. Every culture deals with different aspects of grief, and they demonstrate it in different ways. Some are very open, and some are more conservative and more quiet. So we need to have the opportunity to actually understand them and acknowledge that they are going through that pain, even if we don't see it actively. We have to establish trust. The trust that we need not only with families, but first of all with our partners, our hospital partners, our nursing staff, our doctors that are working with the family. They need to trust us that we will offer the family no harm and that we will not be harassing them with organ donation. That they realize that we are here to support them to work as a team and to actually support whatever the family's needs are. That might just be, just upholding maybe traditions, rituals, or even beliefs that may take some time that our basic social worker, who's already overwhelmed by many other cases, can't do at that point in time. They should be able to trust that we will offer them that helping hand. And obviously at the end, to empower the hospital to give us a call, to give us that opportunity, to empower our community to think about organ and tissue donation as an option and not as an experimental possibility. And now obviously empower the family. We need to have the opportunity to provide that autonomy to families in reference to sharing their information and in reference to what are the next steps. How can they actually make a powerful decision to make a difference and to bring something positive behind something so sad and terrible and tragic at that point in time. So these are something that I always consider important at any time that I go on site and work with families and work with my hospital partners is, I try to rate myself in everything I do so I can see that I'm at 100% every time. You have to give of yourself 100%, and so you can actually receive 100%. And this can be applied at every hospital, every opportunity you have. Now, here we have things to consider and how to prepare. Looks kind of busy, and I'm sorry I did that, but considering the smaller amount of time that we have, I did want to communicate some of the things for your knowledge at this point in time. As I mentioned here, community and religious leaders in donation are very important sometimes because they will listen to them. They will actually go back to their religious leader or community leaders and try to figure out what their position is. And then we also have the information, what we get on Dr. Google or any Yahoo opportunities. But the thing is, it does exist, and that we have to work on providing the right and correct information in that setting. The resources that we have should be available, if possible, in different languages. Spanish here in Northern California is very common, but we do have other literatures in different languages like Mandarin or in the Chinese language, and we have Tagalog for the Filipinos, and we're working on the Vietnamese at this point, and we also have that. This will actually demonstrate how important we are invested in their community and in their culture by trying to offer them appropriate information. At the same time, have a place within the hospital for children and the family, so they can actually have a setting where they can have their private time. Sadly, many hospitals don't have a lot, and it's a shared ICU, but many times hospitals will make an opportunity to give an extra room if available. I've had some hospitals surprise me with giving them that extra room when they have an extended number of families, but that is per hospital, and obviously the opportunities that we establish with our partners to demonstrate how important that is. Educating our care team and hospital staff in organ donations is sometimes needed in real time. We have so many travelers that are coming from different states with different ideas or different aspects of donation that they did differently in their own state. And so I've encountered many travelers who have said, well, at my state I would actually have done this and this and that, or I would have spoken to the family immediately after the first brain examination, or there is no need for ethics counsel here because the family made that decision. So again, knowing your hospital policies and procedures and what they need to do in cases like this for the new staff and also for those who have actually been there for quite some time. Again, continuity of service for families once we've established that communication is essential and very important. Again, the need exists for medical interpretation because we're assuming many times that the family speaks enough or what they call suffice English to communicate and understand what you're saying and what the family is saying. Not only us as providers, but it's a legal right. And recently at the conference I was a couple of weeks ago, I spoke about how important this is, because we're still abusing family members who have had maybe some opportunity to learn the second language of English, and they are being put in a position where they're being interpreting and at the same time offering information of great prognosis and even sometimes even organ and tissue donation, which is a big error from my standpoint, because one, they're family or friends, but they should be able to grieve appropriately like everybody else. And we as providers should be able to offer this family the opportunity to listen to it at that point of sensitivity and obviously in the correct interpretation of what the meaning of the gift of life means. We got to realize also that some certain words in English are not translatable, and the interpreter needs to figure out how to mention or say this at this point in time. Obviously, this I'm sure everybody who does this is very genuine, very respectful, and you're compassionate towards their needs are very important. And obviously, as mentioned earlier, not to make any assumptions. You can share in the grief process with the families, and and many times we have to figure out in the family who could be your liaison, the person that will help you support them and get major information available to them. So yes, you will have to do your homework by looking into the opportunity of working with hospital staff, social worker, palliative care, case manager, whoever that might be who is actually supporting the family at that point in time, and realize that they will actually be helping you establish that trust and rapport that is needed for the next step. And obviously to attend the basic needs, we always check in, if they need hydration, if they need any food. Some families travel far distances to be at that hospital, and they have no money or any assistance to actually maintain themselves at the hospital. Sometimes they want to go home, but they can't. And so whatever needs that they may have at that point in time, it's important to realize that this is something that we can help our hospital partners establish. As I mentioned, things that we can do once we are on site, again, the comprehensive assessment of the case and the family dynamics will give us a better idea how to work with this family and realize that we're prepared to have that conversation at that point in time. Figure out who the family spokesperson is and who is the decision maker. They may not be the same people. Do they have a hierarchy where it's more matriarchal than patriarchal, or do they consider the elders' wisdom behind the new generation who may know differently? So that assessment is very important and is on a case by case with every single family. Realize that we have to look into the possibility that some families have already registered, and some people are not even the eligibility to become organ donors or potential organ donors. Realize if they understand what grave prognosis means and at the same embrace it. Do they understand that? Do they accept it? Is this a new concept for them? It could be that it is something that they've never accepted or has been only granted permission to be legal in their country. Recently, I had a family from India who was struggling with brain death because basically in their country that is something fairly new that the country has accepted as a legal death. Prior to that, cardiac death was the only thing that they would accept. So be prepared for that possibility. Again, decision makers, best place, best timing for this at this point in time. The need of the interpreter, very important from my standpoint. You need that as family support. Also consider checking in reference to the medical examiner or coroner, because they may actually may be thinking, well, I don't want the body touched, I don't want the body, I don't want them cut up, or I want the body whole. And the medical coroner says, well, I'll decide if I want to buy, an autopsy. Now I'll decide if I want to do that. So I'm going to take him over, and that's some more information that the family may need to know prior to making that final decision. Again, the effective collaboration with the care team, because they will be the ones helping you understand where they are in the elaborative of brain death examinations or end-of-life decisions. They may be considering end-of-life decisions measures, but maybe the family is like, well, maybe, but in about 2 weeks we'll talk to you about that. So they may not be ready, and they may be all the contrary. They say, well, I'm probably thinking of withdrawing support tonight, and the hospital says, well, they haven't given us a definite time, so maybe it'll be tonight, maybe it'll be tomorrow. So again, very important how to work with your team to figure out how that actually works. Again, the family dynamics and communication is very important. One of the things that always you can see the disruption sometimes is the extended family and next of kin who are included in the donation discussion. Sometimes it could be a good thing. Sometimes it could be a bad thing. We just don't know how that's going to be interfering in the family's decision. Many times, especially our minority community, tends to have a bigger extended number of families. We have learned, as a minority myself, I can say that we have learned to work around the system in reference to, we are all family. You could be the neighbor. Yeah, we're cousins. Yeah, we are long distance to cousins. And sometimes even because of the last name, it'll be close enough to say, hey, I'm a cousin. So yes, it does happen. We do have extended families, and they may or may not be disruptive. Recently, I had a case where the family had already made the decision to move forward with donation, and the family member's friend, who was very spiritual, was becoming very disruptive to the family and very disrespectful, to the point where they were being very aggressive against the family and very loud and verbal, and at the same time to the point where even the family said, that person does not even have to be here. Please help us with that. And of course, that's where we step in and speak to case management or whoever the manager is at that hospital, and then call security. Because yes, they were not making any support for the family. All the contrary, they were blaming them for wanting to do what they were doing and their decision, and the guilt aspect was very, very strong-headed from their behalf and their standpoint. So we have to be very helpful, and we have to be assertive sometimes with the extended family or friends who think that they're trying to be helpful or supportive. Sherry, in this, this is your slide. Do you want to comment on this?
Sure. Yes. So I have here some of the benefits of timely referral. Obviously, it allows and further enables the hospital and the OPO to communicate well before brain death or withdrawal of care is in motion. Obviously, it helps us to develop our care plan for the family together, and the focus of the slide being to huddle early and to huddle often with the team members that Sal has identified. We've seen again and again through research that it's demonstrated to improve the outcomes in the family satisfaction rates and their authorization rates and how they feel about the full continuum of care, that when we are actively engaged in looking for opportunities to work alongside the critical care teams, social workers, case managers, palliative care, and chaplains. Finally, one fact that was very interesting to note was 75% of families say yes to donation when the OPO and hospital partners integrate the option of donation into the end-of-life conversation, that the decision is made in favor of organ donation when we integrate it into the overall conversations that we are having and putting together team members that are helping support us in those efforts. We are always more successful when we're presenting these options collaboratively rather than independently, or when option for donation is rushed in any way.
Yes, I truly believe. Yes, this, before we start with the case study, in my case, I do want to reiterate what Sherry just said. Again, I can't emphasize enough how important communication is going to be with our hospital partners. Huddles can be of one or two people if you have to make little huddles or big huddles that based on the opportunity, and but the communication is impossible not to happen, because we need to know what the right hand is doing with the left hand, and vice versa. We have to work with our hospital partners. They have to know what we're doing. And again, the huddle is important. And I think that the success, again, as she mentioned, is higher, much more higher than if we did it on our own, or if the hospital did it on their own. And for many of the doctors in the field, they like to know about numbers. They're more analytical in that aspect, and they want to see numbers. They want to see proof that what we're offering them is correct. It's just not our words. So, be prepared to offer those numbers and say them out loud and say, the success rate is higher when we work collaboratively. And that is important for them to know, because the success rate is higher. And so very good to keep in mind. Here I am with a case study, just pretty much to emphasize the importance of this. We had a 67-year-old Asian male who was admitted 2 days ago following an anaptic brain injury, secondary to cardiac arrest, while riding his bike, and he has been declared brain dead. Legal next of kin was a wife. Patient had 2 adult children. Family is Buddhist and not fluent in English, with the exception of the patient's granddaughter. Family's primary language, Mandarin. All information since admission had been relayed to the rest of the family through the patient's granddaughter, including the legal next of kin, who does not speak English. Large family presence at the hospital. So in this case, at this point in time, if possible, I'm not too sure if we can actually have anybody take the lead on, let's see, it's not the right or wrong answer, just to figure out if there's anybody out there who would be able to see what red flags do we have here that we have to consider before we even start talking about donation. Not sure if we can actually make that happen. Don't see any hands up, so let's see, Amanda, what do you think about opening it up to someone? Or maybe I could choose from the list that we have. That would be fun. All right. Interesting. All right, so at this point, we have...
Sal, Karen has
yes.
raised her hand. A student,
Perfect.
Karen.
Sure, can we hear her, or how do we do this?
Hi, Sal. Unfortunately, there'll be no audio coming in from the participant line.
Oh, okay. Perfect. All right, so I should have seen that happening. Okay. So my bad. Thank you, Karen, for, but I'm sure that you have some of the information that would be helpful here. So basically what we have here is a family who had their loved one now brain dead. English is not their primary language, and they're using a family member to translate. And they have a religion, which is Buddhist. And we have to remember that many Buddhist families have special traditions, rituals that we have to consider, and it's all happening fairly fast. And in this case, my role was to assess the family's needs. We were able to bring in, the family had actually requested a Buddhist monk to come in and work with the family. And the Buddhist monk did come in. The family also had many family members present, many of them primarily non-English speaking. We called in one of our family specialists that spoke the language. She actually works in the community, but was able to help assist once we were able to communicate with the family directly and with the granddaughter present. We were able to offer them support in reference to their needs. Sadly, the family was looking into ways of keeping the body whole and ways of wanting to make something purposeful and positive at the same time. With due time, it did require additional time. The family was still having difficulty understanding what brain death really meant, and we broke it down as many ways as we could, and we did demonstrate with them present what the brain death examination looked like and what should be expected. One thing that I did was when we were doing the apnea test, something that I was taught many years ago was to have the family members hold their breath at the same time we disconnect the family, their loved one, and to hold it up as much as what the apnea test would be for 10 minutes, and try to demonstrate if the family or their loved one would actually breathe. This family actually did it, and obviously could not sustain it as much as they wanted to. They couldn't, and it was very helpful for the younger generation to understand that. And the spouse of the patient was struggling still with that. But again, it was with that demonstration of brain death criteria and how terrible this was. They also were able to establish that rapport with our community outreach person who spoke their language and built that rapport to share how wonderful of a person he was and how he was writing through his work as he supported the family, but at the same time he was very active in the community, wanting to share more. Overall, after some time, and they did consult their Buddhist monk, who was very pro-donation and very pro-life, more likely, not necessarily pro-donation, but pro-life, and gave the family the opportunity and permission to make that final decision. The wife ultimately, at the end, said that she had a dream where, in her words, Buddha had come to her and had said it was okay. So she came back to us the next day, and she said that she was going to support the decision of donation because she had gotten permission. And it was impressive because it was one of those things where she could have made any type of decision. The family was kind of split. The younger generation had accepted that there was nothing else to be done. The older generation was thinking of things that they needed to do from their traditional aspects, and ultimately giving the additional time. Now, again, our hospital partners were fantastic in giving us that additional time. We were very lucky that there was really the time and rooms available in that hospital for that period of time, and we were able to extend a time for the family to come to that conclusion. And we were able to save 3 additional lives thanks to this time that we were able to offer the family as we did. And the hospital was also grateful for the support that we were able to demonstrate because they were very doubtful as they usually are, that families will actually consider donation as an option. So from that standpoint, we were very grateful to show that. And at least at this hospital, one of the few things that we also do is a flag ceremony where we raise the Donate Life flag in front of the hospital, and we had all the family members and the families present, and they took a picture with the flag, and then they raised it, and they raised it for 3 days. This is something that families, especially in the Asian community, has been seen as a heroic measure and a beautiful symbol of their heroism. And then obviously this hospital is also starting to put in place the honor walk, which is trending on a national level. And again, families' feedback has been that they feel honored that so many people that don't even know them are doing this for them. So again, very, very positive feedback on everything we can do to honor their loved one at that point in time. The next thing, okay. Sherry, this is yours.
So when I was approached about participating in this collaborative donation conversation, one of the most important things in my mind was to reiterate to the participants what is actually happening behind closed doors. And I see in the participant feedback already a question has been posed by Leslie Soparelli. It says, just a comment, I find many of our hospitals are stating that they need to keep the end-of-life discussions between them and the families without the organ donation staff being involved. Palliative care teams meet with families about the goals of care and the terminal weans without including OPOs. So how do we prevent these huddles from becoming siloed, where palliative care is meeting with the family, the care teams are meeting with the family, and then the OPO sends an authorized requester or family services advocate or a donation advocate on premise, and then they start again from scratch. So what's the purpose of the huddles, and what can huddles do? In a few minutes, we're going to talk about what is said behind closed doors. I wanted the primary focus of my portion of this presentation to cover what is said behind closed doors. And in challenging circumstances where various members of the care team have already been involved. So what do we hope these huddles will accomplish when we're faced with these really challenging conversations with traumatized family members and with the critical care teams that have worked as hard as they can to preserve the life of the potential donation candidate? So how are we mindful of that when we participate in these huddles? Communicating with the OPO early is critical, as I've already mentioned. Providing family support without the mention of donations. Sal touched on this a few minutes ago. Allowing the conversations to unfold in a more organic manner and huddling together and sharing our information with one another and providing, in some cases, a critical glimpse into the dynamics of the family and what might be affecting their decision to go forward with organ donation or not to go forward with organ donation. Every team member that's a part of the care team has a role and an opportunity to participate and collaborate in the huddles. And we want to encourage that. We want to encourage the support of one another, the support of sharing with being on task and focused on the true dynamics of the room before we make an official approach. And how might we leverage one another in making sure that those conversations are given at the very best time and under the very best circumstances. So how do we do that? Well, one way we can help to train our partners in the hospitals and in the community is to give them a glimpse into some of the conversations that happen and how they unfold. I think it's very critical that we don't gloss this over and downplay the dynamics that are unfolding. The majority of the time, if we are invited to a hospital, it is because someone has been given a grave prognosis or the prognosis looks grim. So let's acknowledge that very fact from the beginning of the conversation, that we are all going to operate in a very mindful and active listening mindset, that we are working with people who are clearly not at their best, excuse me, and they are clearly in need of our support now more than ever as we navigate through these very difficult conversations. So what do some of these difficult conversations look like? I put together 3 very specific case studies. When people have asked about the work that I do as an authorized requester or as a family services advocate, I'm often asked, what do you say to them? How can you ask someone for something when they are obviously having, the worst day of their lives? How do we approach those conversations? How do we approach the conversations when they get really sticky, when family members or parents refuse to acknowledge the grave prognosis, or they become entrenched by the patient at bedside? How do we approach when the stigma of suicide prevents the very family members that we are looking to approach from feeling any meaningful regard or positive regard for them, even if it's their own personal misconception leading the conversation? And then what about what is really ugly? When there are preconceived opinions that are often very valid, where there is abuse or criminal activities involved. So my focus on this portion of the conversation is to pull back the curtain and let our community hear what some of those conversations might truly sound like. So in the interest of time, as we are approaching the 3/4 of the hour, I will do the first use case scenario. If anyone is interested in looking at what those conversations look like, you can contact the Alliance and we will provide the case studies in writing as well for your review and for your perusal. Right now we're going to ask that a couple other members join on the audio portion of the call. And Deanna, I believe you will have the first role. This first use case is an authorized requester approaching 2 parents that refuse to acknowledge the grave prognosis of their daughter, and they have become entrenched at the patient by bedside. So I would be introduced into the room by a member of the care team. I ask that they introduce me as the person that's there to speak with them about the next steps in the process. I don't ask for them to acknowledge the specific goals or intentions of our conversation in advance, and I ask that I be introduced as a member of the family care team. Okay, so once I've entered the room, I almost always start the conversation by acknowledging the circumstances that we are in. So I'm going to begin our first case study with this sentence. I'm so very sorry to be meeting you under these circumstances. Can you tell me a little bit about what the doctors have said to you this morning?
They said she was hit by a car near school, and to prepare ourselves that she may not make it. Her DCS is only a 3. It needs to get higher so that we can all go home. But why do I need to prepare myself for the worst? Look, she's still breathing. The machines are still going. I see the monitors with a heartbeat, and she has blood pressure. Help me understand what you're saying. What is the DCS brain flow test? Did she fail? This makes no sense at all.
I understand. I will try to explain this to you as simply as possible. There are actually 2 ways a person can die. The first way we can all recognize very quickly. The heart stops and the patient flatlines, and there's no pulse or no heartbeat. And we shock the heart in hopes that we can resuscitate it. And if it works, we regain a pulse and then the heart beats again in a steady rhythm. Each heartbeat that they have gives us hope for more life. The heart can stop, and that is the first way. But remember, there are two ways a person can die, and yet the other one is rarely talked about. The second way a person can die is brain death. This can be very confusing and tricky for those hoping and praying for their loved ones. Families are often given a grave prognosis, and they really don't understand, like you, what the physicians are actually telling them. Their loved ones, like yours, may have been in an accident or had a traumatic brain injury or had an aneurysm. And to them, their loved one still seems to be breathing. The heartbeat is still there, and their chest is still moving up and down, and the skin is still pink and warm. But brain death is death, and it is irreversible. It cannot be recovered from. Unfortunately, the brain cannot be reset. Imagine that your brain is like a light bulb, and when you're healthy and active, there's activity within the top of that bulb. And in those situations, I would usually make my hands into the shape of a light bulb. And a person who has died from brain death has no activity in their bulb. And I would look through my hands at the patient's mother. The hospital tested your daughter with the CBF, or the cerebral blood flow test that you mentioned. Cerebral meaning brain. So it's a brain blood flow test. And in this circumstance, unfortunately, your daughter, it showed that there was no blood flow to her brain. There was no activity within that light bulb. The CBS test proved there is no activity and no blood flow into some of those areas of her brain, specifically the areas that control her body or her responses. Your daughter has a GCS of 3, as you mentioned. What the GCS is it's a coma scale, it's the Glasgow Coma Scale. And right now, you and I are talking here together, and we both have an average GCS of 15 or higher. Your daughter has the lowest score, a GCS of 3. So I will explain to you how they arrived at that number. You would never allow me to poke you in your eye while we were sitting here talking, or to put my fingers in your throat, anything that might cause you distress or a response. A lower GCS number indicates that a person has little or no response whatsoever to these types of tests. There is no response with the voice or their eyes or their body in any way. And your daughter, unfortunately, had no response to any of these tests. In fact, the movements that you see, the breathing, is only happening because of the machines attached to her body. The machines are moving the blood and oxygen through her body. The machines are the reason her chest is rising and falling. The machines are keeping her heartbeat and blood pressure going because they are providing the mechanical support to her organs. If we removed all of the machines, the blood and oxygen will stop moving, and your daughter will not breathe on her own again. They showed this to you in the apnea test this morning. Remember, she did not ever breathe on her own for over 10 minutes. And I'm so sorry, but I understand this confusion. And if it were my daughter on that bed, I would want to understand how they really knew that my child was brain dead. Your daughter has no blood flow to her brain. She cannot breathe or move the blood and the oxygen in her body on her own. And she has no responses in any way. And unfortunately, brain death is death. It cannot be reversed, and it cannot be recovered from. And unlike the heart, there is no way to restart the brain. Brain death is death, and unfortunately, your daughter died today at 11:15 a.m. Her clinical time of death was recorded today at 11:15 a.m. And if it is okay with you now, I would like to talk about what the next steps are in the process. Your family is in a very unique situation with your daughter to give the gift of life to another person, several people in fact, through organ donation. And most people understand as little about organ donation as they do about brain death. The truth is that there are families on other floors of this hospital praying for their loved ones. They're praying that they will receive their last hope, that someone who is in a unique position like your daughter might be willing to give them the gift of life through organ donation. Your daughter has the unique ability in her final hours to give many people an entire lifetime. As an organ donor, your daughter may give her heart, her lungs, her liver, her pancreas, her intestines and kidneys to others, these life-saving gifts. She could also give the gift of sight to a blind person through cornea donation. And to be a little graphic for a moment, there's a lot of misconception around that specific type of donation. It is not giving someone your eyeballs. It is, in fact, just giving them a small part of the cornea itself. It is as thin as a contact lens. Every gift that is procured or given in this hospital is done with the same respectful surgical procedures and integrity that we provide during any other transplant or any other surgery for that matter. In fact, transplant teams will assemble here at the hospital to help us recover the gifts. In her final hours, your daughter really can give another person a lifetime. Today in this hospital, those transplant teams are here. They're already giving living organ donors the opportunity to give the gifts of life. Those who are voluntarily giving a kidney or a lung or a portion of their livers, a portion of those, to another gravely ill person. The gifts may be given to a complete stranger or to a dearly beloved loved one. Either way, they're giving the gift of life to another human being. And I personally can think of no greater love.
Okay. I think we'd like to donate our organs, but can we know who gets them?
To answer your question, yes. There is a means of communication set up which allows recipients and donors to communicate and to exchange letters. The recipients and their families understand the gravity of these life-saving gifts that they have received from the donors. They often have letters prepared in advance as they fight for their lives waiting on the transplant list. If both parties express a desire to meet and communicate further, we help to make sure that that happens. So the simple answer is yes, if that is what both parties wish to happen. As far as deciding who receives the gift, the primary matching happens by blood type and tissue type matching, followed by other medical factors that we can talk about in more detail if you so wish. There are over 100,000 people waiting on the transplant waiting list, and each of the gifts offered to the transplant team is placed to the best matched patient. The sickest patients receive the gifts.
Okay, but what about her funeral? Can we still have an open casket at her funeral?
That is a great question, and the answer is yes. Many of our donor families have had open casket funerals, and their loved ones have been given the gift of life. They have given the gift of life through organ donation. Again, the same respectful surgical procedures are performed here in the hospital by highly trained surgeons. After the recovery of the gifts, the bodies are then released to the medical examiner's office and finally to the funeral home of your choice. Organ donors have funerals and memorial services just like any of the other patients who have passed this hospital. However, I do think there is one significant difference between your daughter and most of the other people who may pass away in this hospital tonight. I don't know many heroes in real life myself, but I personally believe that giving the gift of life to another person, your daughter would be one that I met. I wanted to take the time to raise the visibility level of those we were asking to collaborate with us. How do we make a collaborative approach to organ donation that affects hospital team members, the care team members, social workers, chaplains, case managers, those involved in palliative care? If we don't include you in the conversations, then how should we expect you to include us in the conversations? I have included a couple more case studies, and in the interest of time, we won't be able to finish them on today's call. I appreciate everyone giving a few moments for questions and answers, but I wanted to raise the veil and conclude with a few of the topics that I touched on in the case study. What some of the options are for the aftercare that was referenced in that case study. And Sal mentioned a few of these earlier as well. And finally, how we can increase our collaboration with one another and in having more open conversations from behind closed doors. I invite any questions and answers or the moderator to go ahead and resume the call.
Thank you, Sherry and Dr. Guerrero. We do have a few questions. Oh, sorry. We do have a few questions. Maybe, Sherry, you could answer this one. Do you take pauses while discussing donation with families, or do you find that doesn't work?
I very frequently take pauses. One, to be mindful that they know that I am actively listening to what they say, that I'm thinking about it, that it's not a simple canned response, that I'm thinking about their child or their family member in those circumstances, and I'm mindful of them giving me their time and consideration. So yes, I do.
Thank you. We do have another question. How would you start your communication with your hospital partners once you're on site?
Sal, would you like?
Sure. Well, the way I start, if you want, Sherry. Personally, I've already tried to establish a communication style with the hospital doctors or the nursing staff, social worker, whoever that might be, informing them of why we're there and that we're evaluating the potential, and like to figure out, what the plan is, the plan of care for this family, and at that point in time, inform them that once we've been able to assess that we may be speaking to the family once they have actually come to consider end-of-life decisions, or that brain death declarations are coming up fairly soon. So we try to make a plan with them to actively be part of that communication. As Sherry mentioned, we need to inform them. We need to keep them informed of our plan so they can keep us informed of their plan. And we have to take into consideration also that many staff, they're on for certain days or times, and so we have to be maybe a little repetitive, and we can't assume that everybody's being told the same story or the same message constantly. Sherry?
I'm very mindful that the critical care team has just been engaged with with aggressive life-saving measures. No one wants to lose a patient. So I'm very careful to acknowledge the efforts that have been made in reference to that patient. And I also ask them to be an ally in the process. And I ask them to introduce me to the family as another member of the family care team. I've found that ally building, warmer offer is very helpful.
Thank you. In essence of the time, we do have one more quick question, if you could answer it.
Okay.
Not all families want a spiritual counselor. Should they be considered as an automatic option with every family?
Never.
No.
Never.
No. I've had families where they're not religious and they straight out say, I'm not a practicing Catholic, but I believe in God and I'll pray by myself, type of thing. And okay. So no, can't do that.
Absolutely not. Absolutely not. Making that assumption that even the family members are the same faith practice is a grave error, in my opinion.
Thank
Correct.
you. Deanna, with that said, we'll turn it back over to you.
Thank you, Amanda. Well, with that being said, on behalf of the Alliance, I'd just like to extend a sincere thanks to Dr. Guerrero and Sherry for joining us today and to share your expertise on this topic. You're both clearly well-versed in this arena, and we appreciate you for sharing your wealth of knowledge. Additionally, I'd also like to thank Amanda for taking the time to join us today and moderate our webinar. So thank you, Amanda, for that. And to all of our participants, as always, we thank you for your time, and we hope you enjoy the rest of your day. Take care.